Today, the topic today will be the effects of dementia caregiving in late and young onset dementia. So although we are meeting virtually, we acknowledge that Baycrest and our related Toronto Central Behaviour Support Programs operates on the traditional territories of many Indigenous nations, which have cared for the land of thousands of years, including the Anishinaabe, Haudenosaunee, and Huron-Wendat peoples. And we recognize the current treaty holders, the Mississaugas of the Credit First Nation. This land remains home to many diverse First Nations, Inuit, and Métis people, and is subject to the dish with one spoon wampum, an agreement on to peaceably share and care for the Great Lakes region. We are grateful to have the opportunity to work on this land today. You may live and work in different territories, so we encourage you to reflect on the land on which you are located and to consider your relationship to the land and to the people who are the traditional keepers of the land. Okay, so some basic housekeeping. You'll notice that your microphones are muted. This is recording, as you would have heard. We'll have opportunity near the end of today's session to do a Q&A, and so you'll be using the Q&A option at the bottom of your screen in the chat. Today we have Agnes, who's helping from telehealth for technical support. And then we'll do a wrap up and talk about your certificate of attendance, which you can get by just putting in the chat box that you would like a certificate. We'll make sure we get that your way as well. So today I want to introduce Dr. Andriana Schnall. So she comes with a lot of experience. We're so happy to have her. She's the program director of the Andriana, I'm going to butcher this. Koschitzky Center for Innovations in Caregiving at Baycrest. Andriana has over 30 years of clinical experience working with older adults living with dementia and their families, including outpatient community services, long-term care, and inpatient services. She was the recipient of the Baycrest Outstanding Innovations Award. Andriana has an academic appointment with the University of Toronto at the rank of assistant professor and teaches at the Factor in Wencash Faculty of Social Work and at the Institute of the Life Course in Aging. Andriana's passion lies in understanding the profound impact of dementia on individuals and their families, particularly the challenges faced by family caregivers. Through her research-driven approach and compassionate clinical practice, she has made significant contributions to the field, aiming to enhance the quality of life for both caregivers and individuals living with dementia and the healthcare providers that support them. That being said, welcome, Andriana. I'm going to stop sharing and give you the chance to share your PowerPoint. The floor is yours.
Thank you so much, Kara. And let's see how smoothly I could do this. Can you see my slide?
Yes, we can.
Yeah. Okay. And I just wanted to tell you that I am so happy to be here. As Kara said, caregiving has been my life work, and in particular, really my area is young onset dementia. That's really what got me interested in research and in learning more about this population. So I'm really happy to share this information with you. I hope that it's interactive, and I hope that we have enough time for questions at the end. I'll make sure that I finish on time. And if I'm not, Kara, please feel free to stop me. I have no disclosures. So with that, I just want to tell you a little bit about the Koschitzky Center for Innovations in Caregiving. And really, it's a Baycrest hub for innovation and dissemination of best practices in caregiving. It's a fairly new program, and one that I'm 100% committed to growing. For today, I just want to set the context around dementia caregiving and important information that I think you need to have. Some of the effects of dementia caregiving, both in late onset dementia, and of course that's people that develop dementias over the age of 65, and the young onset dementia group, which are those that develop a dementia under the age of 65, and in particular, the effects on the spousal caregivers and children caregivers. And finally, I'm hoping that we'll have time to talk about how to best support caregivers and what the evidence shows. I always start my presentations with this quote from Rosalind Carter. where she says very astutely that there are only 4 kinds of people in the world: those who have been caregivers, those who are caregivers, those who will be caregivers, and those who will need a caregiver. And sadly, I just read on the news a couple of days ago that Mrs. Carter has dementia, and the family has asked for privacy around this time, and that they will not be prepared to comment on stages or anything else. So who would have known? And maybe she knew, she was preparing for it. Anyway, I also start with a couple of definitions around language that I think it's important. I use the term caregiver, and I'm very aware that a lot of people are not comfortable with this term, because caregiver means that the person providing care is giving, and that it's not a reciprocal relationship. And we know that it is a reciprocal relationship. Some people prefer the term carer, especially in the UK, Australia, that's the term that's used. Other people prefer care partner. I don't have a preference, I mean, because I still haven't found language that I'm happy with, but I use the term caregiver because that's the one that if you Google this comes up a lot and what people most understand. And the other thing is I shouldn't say never, but I try not to use the term your loved one. I find that not everybody who's a caregiver loves the person they're looking after. Sometimes there's a long history of conflict in their relationship, and people do it out of filial duties or different reasons. So I talk about the person's spouse, partner, relative, just so not to assume anything. So let me talk a little bit about just generally the effects of dementia caregiving. And before I even talk about this, I want to make it very clear that if you look up the literature, you can pretty much find any outcome that you want. And the reason is because there's a lot of methodological flaws in caregiving. And even though research really started ramping up in 1995, there are a lot of methodological concerns. Main one is that for studies, adult children, spousal caregivers, neighbors all get lumped under the category of caregiver. And so when we're looking at effects, if you're a neighbor, your effect on caregiving for your neighbor will be very different than if you're a spouse, a partner, or an adult child. So we need to keep that in mind. And when you read the literature, please try to see who do they include and what do they mean by caregiver. And the other piece is that there's no definition. First of all, there's no definition about caregiver. I mean, that would be helpful. And the second one is that studies mix up burden, depression, stress, quality of life. And so when you're comparing from study to study, you're comparing apples and oranges, really. Oops. There's variables also that shape the caregiving experience, and these are generally not controlled for. So for example, the level of intensity of the care provider. So if I live with my partner 24/7 and I'm doing all of their ADLs and do all of the IADLs, that is very different than if I'm a caregiver of my mother who lives 3 blocks away, and I just do shopping, groceries, and take her to medical appointments. The other piece is the duration of the time spent in a caregiving role. We know time, the longer people are caregivers, the more burden they will experience, and that's generally not controlled for. The type of relationship, so if it's my mother, if it's my partner, if it's my child with young onset dementias, we're seeing older adults looking after their children with dementia, and also the quality of the relationship. Was this a close, loving relationship? Those generally have better outcomes than people where there's a long history of conflict. So a father that was abusive, the daughter now looks after the father out of duty. but still has a lot of anger and resentment. The piece around diversity of families, around culture, around gender, that's a huge other topic, and generally not controlled for. Also, timing of entry into the caregiving role. So if you become a caregiver in your 20s, that's very different than becoming a caregiver in your 80s. And you can just think about in your 20s, it may affect your schooling, your prospects for work, and forming relationships and your own family. The transitions in care that are experienced over time, transitions in care, say from the community to long-term care or from the community to hospital, those are periods of crises for people. And so where are people in that trajectory overall? Do we know? Also, whether we live with the person we care for, do we live close by? Or are we doing distance caregiving, which comes with its own set of difficulties? You're not doing the physical day-to-day tasks, but you're worried, and you may want to plan and manage from afar. Also, are you a caregiver of somebody who's newly admitted to long-term care, somebody in the community? That matters. Then the multiple roles intersections. So am I 40 years old? I'm not. Do I have children in my home that I look after? Plus I work, plus I look after my parents, plus I have a disabled brother. So those things make a difference. Of course, socioeconomic status of people and gender. And as you can see, caregiving is affected by all of these variables. And between these variables, not having a proper definition of who a caregiver is, plus measuring different things, creates difficulty around research. However, any of us that have been in this field for a long time, you don't need to read the literature to know the effects of caregiving, mostly caregiver burnout. And by that, people get easily frustrated. Some people present as feeling tired, not enjoying the things they used to enjoy. They're forgetful. They get angry quickly. They can become anxious and depressed and feel hopeless or helpless. And as you can see, these look very much like depression. However, this is where we don't have consensus around, do we call it depression? Is it burnout? I guess we call it caregiver burnout because in the absence of a diagnosis, that's safe. Caregiving comes with difficulties in terms of, for men mostly, metabolic illness. There's physical problems. So for men, diabetes, high blood pressure, high cholesterol, higher risk of heart attacks and strokes, although some newer research is showing that this is happening for women as well. It just takes longer to happen. There's social isolation. There's financial concerns. There's conflict in families. And six, being the caregiver, whether you're a spouse or an adult child of somebody with dementia, increases your risk of developing dementia by 600%. I mean, that's not minor, it's a huge number. And so this is common throughout caregiving. Other things you may want to know about when you're looking at your clients. Overall, spouses that have lower incomes who use emotion-focused coping. So for example, I'm frustrated, I'm gonna go drink a couple of glasses of wine, and have fewer social supports, experience more caregiver burden. And that makes a lot of sense to all of us that work in this field. So spouses have experienced more burden than, say, adult children. And is that because it's your life partner? Is that because you live with them 24/7? Probably all of it. There's also a consistent finding that there are gender differences. women who were caregivers also have more psychiatric morbidities than caregiving husbands when compared to non-caregivers. And independent caregiver predictors of depression include low income, the nature of the relationship. So wives are the most depressed, and sons of male patients least depressed. So when we look at wives versus adult children, so a daughter to a mother is more difficult than son to a father. I mean, again, take this with a grain of salt. I'm not sure of these findings. But what we know for sure is that hours spent caregiving matters. Oh, I just want to go back. When I said take it with a grain of salt, it depends on their relationship. So we know plenty of father-son relationships who are very close, and this would not stand. So really those variables about the quality of the relationship, where people live, whether they live together or not, have a very strong impact. And functional dependence matters. There was a really good systematic review here in 2020, and it was international in nature, and they looked, I don't know, over 5,000, I don't know how many studies, qualitative studies in English, French, and Spanish. They ended up choosing just 81 that met criteria. And what a lot of the research shows is that sometimes it's the logistical tasks that create the burden. So the personal care, the housekeeping, the medication management, the managing finances. However, there are also emotional demands of caregiving, which really have an effect. People have fears about loneliness, they fear about what the future holds, they worry about financial repercussions, people are sad, they experience social isolation. There's sleep disorders associated with caregiving, and that's above and beyond the care recipients not sleeping well so that the caregiver's up at night with the care recipient. It's because caregivers have their own worries and stay up at night not sleeping because of their worry. And as we know, sleep disorders are associated with increased risk of dementia. The other piece is that there's no time for personal care, leading to difficulties maintaining their professional and social lives and other familial responsibilities. And we know plenty of family caregivers that have to cut back work because they just can't manage it all. And the other issue that leads to negative consequences are the comorbidities and symptoms of dementia that lead to other issues. So for example, feeding issues, falls, decision-making later on, and the list goes on and on. And the reason I'm presenting this systematic review is because they really went through all the different, they tried to find the ones that with good methodology so that they can compile certain things. And I think for all of you, these things will resonate. So problems that caregivers encounter, what they say are their frustrations. And this is interesting because it's all over the world. Inappropriate medical formal support, and that's feeling that your doctor doesn't listen to you, that you don't get the answers that you need, that healthcare providers, not just medical, but all of us, are not necessarily there for them when they need us. The other problem is this idea of the disease progression. It's like this living with constant loss. And you know, when somebody says, oh, the roles are reversed, I'm looking after my mother now, it's like I'm mothering my mother. And there's a big difference, because when my mother looked after me, she knew I was going to grow up and be independent. And it's a totally different relationship altogether. You cannot compare. But what's so difficult in dementia caregiving is that it's loss after loss after loss. There's also huge financial consequences for families. They have to make difficult decisions, DNR, feeding tubes, placement to long-term care. And then these are illnesses that last a long time. And really, so what, in terms of intervention, what would help families are things that giving people appropriate medical counseling, having the formal supports and professional supports. This is something that for BSO, this is what you're doing. And so this is great because this is exactly what families are saying they need. They need their own emotional support. They need an early diagnosis because all those sometimes could be years trying to figure out what's wrong and what's happening are devastating. And families wish they had better family and friends supports. And this may not be something that professionals can help with, but I argue that it is something that you could help caregivers explore. How could they improve some of these relationships? And depending what your role is, but if you're a social worker, these would be really good strategies to focus on. I don't want to leave out this idea of positive aspects of caregiving. And I don't want you to think that people are not looking at them because it's not all doom and gloom. There is research that shows that there is some evidence that there's rewards to be gained by looking after somebody with dementia. And things that contribute to positive outcomes include like the caregiver feeling like I want to do the best by my partner. Also, I know that if it would have been me with dementia, he would have done the same thing for me. And some people are able to find satisfaction in the situation, and it's a way of coping with what's happening. However, just because there's positive aspects, it doesn't mean that anybody would choose to be in this role. But later on, this is a piece that people could start working on, like how we all try to find meaning in life. Those of us that worked with caregivers for a long time know that later on in the caregiving trajectory, people start kind of making sense of this journey they've been going through. Okay, so now I want to talk a little bit about young onset dementia. And how it differs. First of all, most people with young onset dementia are employed at the time of diagnosis. They have dependent children and or parents. They're generally physically fit and active. They have financial commitments. They generally have mortgages, children in schools and universities, and they're more likely to have a rarer form of dementia, such as frontotemporal dementia. And there's tremendous stress due to the extraordinary consequences on emotional, physical, and financial areas of life at a time that it's not expected. And really, a lot of the unique problems that family caregivers experience are due to the unexpected timing of onset. Also, the financial concerns are way worse. And there's a triple financial threat. So first of all, the patient's loss of income, they may have to stop working and they're not 65. And it's hard to qualify for ODSP in Ontario if you have a partner that works. And people don't necessarily qualify for financial programs. Whereas when you're over 65, at least you could probably get old age pension and CPP. And you were planning for retirement, or more likely to be planning for retirement. And then the other threat is that the partner has to cut back or quit their job to be a caregiver sometimes, or they get fired. The other issue is that most services are really designed in dementia are designed to help those who are older, and things have changed a lot. But when I started my career over 30 years ago in this area, people couldn't go into long-term care facilities unless you were over 65. You couldn't go into the day programs. There were so many criteria and things that people couldn't, couldn't avail themselves of. So they really fell through the cracks of a lot of the systems. The other thing that is unique to this group is the amount of misdiagnoses. So people in the 40s, 50s, they start getting treated for depression, stress, burnout, menopausal. A lot of women are told it's menopause, don't worry, it'll pass. Marital. So when I was doing my research with spouses of people with young onset dementia, you'd be surprised how many people got sent to a therapist. And they would say, well, the problems you're having in your marriage are due to marital problems, when in fact, there were really problems of cognition and personality changes due to these dementias. And on average, it takes 3 to 5 years to diagnose young onset dementia. And sometimes it comes at points of crisis. So I had clients who wouldn't pay their CRA, and typically, partners share tasks. And so say one of them pay taxes, the other partner is not paying attention because the other person's been managing well. And then they find out years in, like taxes haven't been paid, that they're in huge financial crises and they knew nothing about it. I like to talk about this case I had early in my career. There's this woman who I call, she cashmere and pearls from suburbia woman, very prim and proper. And all of a sudden she started taking up riding her motorcycle and picking up young men. Nothing wrong with any of that. In fact, I remember thinking, wow, how lucky to feel liberated at a particular, after raising your kids, it's like, enough of this, I'm going to do what I want. And this is what the family were thinking. It turned out, of course, any of you could guess that she had FTD, behavioral variant. And so sometimes this is the telltale sign, is when people do things are so out of their character, outside of what they would have done before. What's different in terms of caregiving for the younger set is 82% of people with young onset dementias are cared for by their families. Most family caregivers tend to be in their 50s, and males as well as female. In a study comparing persons with young onset dementia versus late onset dementia, found that caregivers of people with young onset dementia reported higher levels of burden than people with late onset dementia. It makes sense, although I question how burden, was framed. It's just different burden. So I could imagine if you're an 85-year-old spouse, partner, so say you're a petite woman, you're 85, you have osteoporosis, you're frail, and you're looking after your partner who is 90 or 85, double your size, and you're doing ADLs or something for them. That would be pretty stressful in a different kind of way. So than a 50-year-old partner who has to give up their job and look after somebody with a total personality change, that would also be more stressful. But pain is pain, and it's hard to differentiate what we mean when we say a higher level of burden sometimes, because the way the burden is defined in the literature changes so much. The other piece is that people with that were looking after somebody with young onset dementias had a longer duration of caregiving, and we know that time of caregiving is associated with level of burden, so that makes sense. And another explanation for the high strain reported in younger groups is really just not being prepared for this role at this stage in life. There's also high levels of anxiety, and that makes sense. And women are more anxious than men. There's also very high prevalence rates of depression, especially spousal caregivers, and a unique anxiety and burden associated with young onset dementias is the worry about the genetic component and transmission to children. So, some issues for couples. The other thing we know is that of all dementia caregivers, spouses are more at risk, and this is true for late onset and young onset dementia. Spousal caregivers of younger people with dementia have greater perceived difficulties than older spouses and greater level of burden. This is the same thing, more studies that showed that. I don't know. The other big concern is that spousal caregivers in the young onset group are more at risk of experiencing loneliness compared to other caregivers, such as parents or children. We also know that the younger onset dementias will have a detrimental effect on the quality of the relationship, and this is because of the higher prevalence of FTDs and personality changes in these dementias. And the other piece is the point when dementia starts will affect the relationship differently based on, I mean, you could be 40s or 50s and still have children in the home, or you could be 60, 55, 60, be newly retired and have less commitment. So you could see how the stage in life when you have a young onset dementia will really have an impact. So in the young onset group, the pre-diagnostic and early phases of dementia feel very different. Because a lot of people, marriages break down because people don't understand the changes in behavior. The stress level is so high for people. Some people are in denial, and I remember some clients, and part of the research, when a husband said to me, well, I didn't realize there was anything wrong with my wife. She was still cooking and making good meals, and it dawned on me how, depending on the kind of relationship and the roles, that to him, that would have been an indicator that there was a problem. Other people are really in denial because people will do bizarre behaviors and partners can explain it off. So there was one woman who took to buying carriages for the dog to walk dogs, but if one was good, 20 was better. That's not normal behavior. But the husband didn't think there was anything wrong with that because she could afford it. So it was kind of like, it's okay, she has the money, without thinking, does that seem right that she's buying all these strollers for the dog? And for some people, it's relief. It's really this understanding that, okay, this explains what we've been going through. And so it's not all that bad. And then in the middle stages, which is the largest chunk of really of the caregiving experience, is a series of crises that people go through. So some new problem arises. So now your partner can't drive anymore. You have to adjust to this. What are we going to do for transportation? Never mind that. How am I going to get him to not take the car when I'm not there? How am I going to, some people are very savvy. You remove the key, they can figure out a way to start the car anyway. And you deal with that problem and things are stable perhaps for a while, and no sooner you finish with that, some new problem arises. Like a call from the police, your partner was caught shoplifting. And now on top of it, you have to deal with law enforcement, legal teams, as if you don't have enough to worry about. And of course, you have to pay for all of this, right, out of pocket, unless you qualify for legal aid, which most people may not. So the stress is not high enough that now you need all these extra things. And then the later phases of moving on. How do you, I remember a client saying to me, all that's left for me when he passes on is to be a Walmart greeter. And she was an educated woman, because she said, the majority of my career at a time that it should have been, moving up, having promotions, building my future. Now, like I haven't done any of those things. I've been at home looking after him. And what am I going to do? Never mind personally, but even financially. And I'm not going to go into those. I want to talk a little bit about how young onset dementia affects children. It affects children. And there hasn't been a really understanding on how to best support them. And children tend to not want to say anything, not to demonstrate their emotions, because they don't want to burden their parents or the parent that's a caregiver any more than they have to. But of course, there's a lot of sadness and anger and guilt. I remember a client, the mom had young onset Alzheimer's disease, but this is before they knew it. And the daughter had friends sleeping over. And at 2 a.m, the mother came screaming and raging, talking about, sending these kids home. What are you doing in my house? Go home. You could imagine the daughter, how mortified she was. Later on, they realized what the issues were. But at the time, and even when you know that there are problems, it's really horrible for kids to live through some of this. And sometimes kids hear things, especially with the FTDs, they're told horrible things. Also, the incidence of sexual abuse with a disinhibition. I remember having somebody who was a principal at a school who started molesting children. That's how he was diagnosed. And the wife being horrified, because in her mind, she thought, well, was he a pedophile before? And I didn't know this. Is this a dementia, or is this who he is? And the children, and now having to protect your own children, right? So does that mean that my kids are in danger? There was somebody else who was had custody over her grandchildren. And who do you choose? Do you choose your partner, your lifelong partner, or your grandchildren that are in your care? Kids have fear that they'll get the disease and that maybe they did something to cause this to their parent. Teenagers may become resentful when they have to take on more responsibilities for helping around the home. And if you're interested, we did a caregiver webinar. You can find it at Baycrest at Home under resources on young carers and the burden that they share. And of course, some of them have done great things with that as they moved on. But it's a really interesting webinar, so you may want to look at that if that topic interests you. And sometimes we run the risk of children doing too much. So we have kids that take on a caregiving role of like bathing the parent. Is that okay? Not going and playing with friends after school or doing sports because they have to run home to look after the parents. University-bound children may become reluctant to leave home to go to school. So you could see that for young carers and young caregivers, this is a huge issue. One that we're trying to understand more. The young caregivers organizations do a great job at trying to support. but they're doing it for all illnesses. And dementia, and especially the younger onset dementias, are very different because there's the personality changes. So parents will tell the children all kinds of horrible things. And so it's, even though you may know it's a dementia speaking, you could only imagine how horrible it feels to be told certain things by your parents. So also, as professionals, this is something that you need to pay attention to. If you're doing home visits, if you witness child abuse, you need to report it. And I could see how some people may be reluctant because, again, could you imagine how horrible it is? You have a partner, say your spouse develops dementia, young, FTD, he's 50, you're 48, you have children in the home, you have enough problems, loss of income, you don't know how you're going to manage your job, you've gone stress leave to figure out what to do. Then the children's aid comes because somebody's reported abuse. They witness something, screaming, yelling, all kinds of things. So you may feel like, oh my God, like how could I put that on this family, on the wife mostly, or the caregiver partner. But yet we have to, it's our professional duty, and the well-being of children matters. So these become very difficult cases to support. And I want you to keep an eye on these cases as you see them, even if it's grandparents, even if it's late onset dementia, there's lots of grandparents looking after grandchildren. And what does that look like when a grandparent or anybody in the home has dementia? We see examples of people with dementia looking after grandchildren or children, and we wonder, is this a safe situation or not? So these are important things to discuss. They're not clear cut. It depends. But in ideal situation, the children's aid is supposed to be there to provide support, not to punish. But it's something that you really should consult your supervisor on how to deal with those cases. They may not be the norm, but they come across enough times that we need to know how to respond to those cases. So in conclusion, just for the young onset piece, this is a really under-researched area of dementia care, although in the last 5 years or maybe 10, it's become more important. Huge problems around changes in employment, really important when you're working with these families. What I used to tell people is whatever you do, don't quit your job, or don't let the person with dementia quit their job. Just go on medical leave until everything's sorted out. Because I don't know if you're aware, but if you're not performing at work, your employer may give you a letter to sign that you're fired, and the letter states that you can't appeal it later. So it's not like you can go back 3 months later and say, oh, we went to Baycrest, whatever, got a diagnosis, I have young onset Alzheimer's disease, and that's why I wasn't performing. Too bad for you. And we've had cases of people with very strong unions. They took it through the union and they did not win. So really important that you advise families just go on medical leave until all of this is settled. You want medical leave because you don't want people depending on their jobs. Like if somebody's a bus driver, you don't want them driving a bus. If somebody's a teacher, you don't want them, certain jobs have a lot of risk associated with them. So you want to protect everybody, protect the population they serve, but also protect the person living with dementia and their family members, because going on medical disability if you're under 65 is a lot better than being fired and then not having access to any. And if you're fired, you can't go on ODSP. Then you have to prove that you have this new illness. It's not easy. And really, it's the off timing of these dementias that create such difficulties for people. Let me see if there's anything else, because I'm very aware of the time. Yeah, so let me just quickly go through this one. Implications for practice. If you see anybody with young onset dementias, you must, and by you, I mean people that are going to provide psychosocial interventions, assess those partners right away. If you don't do it as normal practice with people, older adults, for sure do it with younger people. Important to provide psychoeducational support, like around finances, powers of attorney, self-care. Psychotherapeutic support is crucial for this group. And really your goal in supporting them is to mitigate crises in the middle stages. We need multi-pronged approaches. Like families say that one of the most important things for them is to have somebody that they can call when they need, when new questions come up. People don't want to wait till their visit in a week or 2 weeks. Support groups, respite, counseling. The other piece is for the younger groups is preserving the sense of couplehood. It's hard to do activities together that are meaningful in the absence of, friends quickly stop inviting you, and people really, it's a big problem. People complain that they're very alone. So we did a program a few years ago. We had a grant around doing spinning like bike classes for couples with young onset dementia, and it was great because it was self-care for the spouse, it was physical activity for both who needed it, and then we had a social worker and coffee and refreshments, and there were social workers to kind of chat. Programs like that we found to be very efficacious. It's hard to maintain those programs because if we were to charge for something like that, this population really has very little funds for anything. But ideas, physical activity together is really helpful. And not to forget in later stages to offer grief counseling and preparation for post-caregiving years. That's true for both young onset and late onset. And I'm going to stop because we're running out of time.
Thank you very much, Andriana. This was really, really very insightful. So now we open up the floor for some discussion. Please use the Q&A box in the chat. I did see one question in the Q&A box just asking, what if family refuses to help support the caregiver?
Well, listen, if the family refuses to, and who's the family, right? Like, there's conflict in families. So to be more specific, so if the caregiver is the spouse and the daughter doesn't want to help the spouse, it's complicated because sometimes what if it's a second spouse, and there's, and there are issues around there. It's hard for me to give you what to do because sometimes then why isn't the other person helping themselves, right? Like, what does it mean not to help the caregiver if the family refuses to help the caregiver?
So Jasmine, I'm not sure if you want to take a little bit more in the Q&A or use the chat box as well to elaborate a little bit more on your question. Susie, I saw that you put your hand up, but if you can please use the chat box or Q&A, that would be great. I'll give Susie a moment. Oh, no, she said that was a mistake. No worries, Susie. And some compliments that they really appreciated the information. Any other questions or comments for Andriana? Question, will we receive a copy of this recording? So yes, the recording actually will be available on the Ontario CLRI and BSO websites. So you can access that later on. Another question, are there any resources available for family and caregivers?
Are there any resources? There are a lot of resources for family caregivers. And the big barrier is not a lack of resources. The big barrier is family availing themselves, even when you give it to them, for them to use it. And really, this is where the skill for clinicians come into what resources. You have to give the right resources at the right time. So if you meet somebody and they have a new diagnosis of some sort, to give them resources unless they ask for about funeral arrangements when they're dealing with somebody who's wandering is not effective. In fact, they're going to feel that you haven't listened to them. So there are resources on the Baycrest website, in the healthcare portal, the Alzheimer's Society, Baycrest at Home has resources. Finding resources is really not the issue for you as clinicians. It's how do you give, so some people you can lead them to a webinar, but they may not have an hour to listen to it and they want distilled information. So just, so you have to figure out what would be best for this family. Do they need it written down by you, step 1, 2, and 3, and you explain it to them? The other piece that we know around supporting family caregivers is that giving them resources is useless to them, and they resent that. Resources have to come with a clinician attached to it for them to be used properly. This is why we don't have admin people handing out resources. So because you can curate the resources to whatever need they're going through, whatever issues they're dealing with, and also explain and make sure they understand.
The comment about the resources was more specifically resources for family and patients with young onset dementia, i.e. group therapy, etc.
Yeah, so group therapy. We run at Baycrest, through Baycrest at Home. There are support groups for younger onset dementia couples. The Alzheimer's Society also has groups for young onset dementias. A lot of the Alzheimer's, we have through the healthcare portal at Baycrest some resources for young onset dementia. And of course, the Alzheimer's Society has quite a bit in terms of education. In terms of programming, pretty much support groups is where it's at now. A lot of what we found when we did, Rini Kleiman's, that a lot of you may know before she retired, used to run, her and Donna Margles, a lot of the young onset support groups, one for adult children, a separate one for spouses, and peer support was found to be really beneficial. Once the groups were done, they all wanted to meet on their own. In the early days when we had the first young onset dementia group in the year 2000, early 2000s, people after it finished, they would meet at the what's a chicken place? Swiss Chalet at 401 on Yonge Street, because that was close. People living in different directions, they could take the 401 and meet. And then they would have a meeting in the east and on the west. People, and for years, those relationships really flourished. The caregivers, a lot of caregivers find that meeting people like them, and they get together for dinner with their partners with dementia, because it's embarrassing. Imagine being with somebody acting out, like where do you go to a restaurant? Like where, but they understood one another, and so they form groups to socialize. So those tend to be very beneficial for people.
Great. So we have about 5 minutes left. A couple more questions to get to. Is there an approach to disclosing a diagnosis to younger children or teens?
Yes. So you may want some resources for the Young Caregivers Organization, but it depends on their stage, right? So it's different 3-year-old than a 15-year-old. Kids are a lot smarter than we give them credit for. If you think your kids don't know, even when they're young, they know. Their stories. We had a speaker, Valine Campbell, in one of our caregiver webinars. She wrote a book about explaining to a child about the grandmother with dementia. The Alzheimer's Society has a lot of books and resources to support that as well, but it has to be age appropriate. And lying does not work. I mean, kids know more than we think they know. And so pretending that there isn't a problem is not a solution, really.
So Jasmine elaborated on that initial question about what if family refuses to help support the caregiver. So she said, caregiver asks for help, but family is unavailable or say they help enough. Other difficulties are not understanding the person with dementia's financial situation. Family under the impression that there is a significant amount of money to pay for care, but it is actually very minimal.
Well, so this is typical. This is the bread and butter of a lot of social workers, is like dealing with family conflict. And so in a lot of families, diagnosis of dementia brings up conflict, whether it was there before or not. Siblings, I always joke, you can have siblings in their 50s, they come to your office and they behave like 2-year-olds fighting, you know. You got to navigate those waters. Sometimes they need professional help to help them, or mediation to help them solve those issues. Issues around money, issues around second marriages come up, issues around, I call it the son from California versus the daughter from Toronto, where the son from California yells and says, do this, you're not doing this right, you should do this. And the daughter in Toronto is frantically trying to manage things. There are all kinds of permutations to these crises. They're really crises for families, because now not only you have to deal with the person with dementia, but you have to deal with the rest of your family, who may or may not support you in what you're doing, who may or may not understand, and what if you have 2 powers of attorney, adult children? Typically this happens too. One has power of attorney for money, one for care. And then the one for care says, I want mom to stay at home. We're going to put a reverse mortgage on her home and do 24 care service. And this son with the power of attorney for finances says, absolutely no way. She's going to go to long-term care and we're going to sell her home and keep the money. I mean, maybe they're not, you know, but basically there's a lot of struggles around the financial piece. And, you know, people feeling deserving of this money, adult children taking advantage of this this situation.
Well, I know there's 2 other questions waiting. Unfortunately, I don't think we'll have time to get to it. For sure, you can always email myself or Agnes or Tanya online as well. Just to get your last minute questions answered by Andriana. Thank you, Dr. Schnall. This was really, really informative. So as mentioned, in terms of this website, or webinar rather, it will be posted on the Ontario CLRI and the BSO websites. You will get an email, a survey at the end, which will do a brief evaluation, and that will give you the opportunity to request for a certificate. Again, thank you everybody for your time today. In terms of CLRI, you can connect with them. Here are the options on the site right now. And have a wonderful day.
Bye. Thank you.